Uh, so you want me to start right away?
Yes, sir. I'll just start the session, sir.
Yes.
So, welcome you all to this very important webinar, the end of life care process, ethics and intricacies. So, today we have with us the eminent speaker, Dr. Mani R.K. Mani, sir, with us. So, he's going to talk regarding the what is the care plan of a dying. And as we all of us know, this process is evolving day by day in the Indian law, and many of the intensivists actually they need to know more detail regarding such an care plan, because most of the times there is no definitions and most of the processes are not defined in many of the hospitals. So that is the reason a very clear overview of the end of life care process is very important. And who can talk better than sir? Because I know sir, and whenever I remember the oncology ICU, the neuro ICU, and the care for the terminally ill patient, I think he is one of the mentor in this field since long. So today we are fortunate to have him here, and today is our 37th episode of Apollo Mumbai Critical Care Learning Network, and I encourage all the students to participate in this and to make this session very interesting. I am Dr. Gunadhar Padi, Senior Consultant, Critical Care Medicine, and with me the other moderator, Dr. Akhilesh Tandekar, is Critical Care Specialist Consultant, Apollo Hospital. And today the session will be also hosted by two or three of my students, Dr. Ganesh and Dr. Anjana. So sir is going to make this session very interesting and interactive. He will make some certain case presentations and certain questionnaires. So we'll discuss during the talk only. So I request Anjana and Ganesh to answer the questions or the whatever the the questions asked by sir. And so let's go ahead. So with this, I hand over the mic to sir. Sir, please start the session and welcome you, sir, again.
Good evening to all, and thank you for the opportunity, Dr. Padi and his team, to address the students. Now, you see, end of life care is very complex and challenging, as well as essential decision making, because there's an intersection of various things: your diagnostic and prognostic abilities, the ethical underpinnings of the decision making, and all the nuances and intricacies involved. So we'll discuss that in an interactive way, and I hope to be able to address your questions as well at the end of it. Sorry, this moving now. A few months ago, there was a publication in the intensive care medicine. You know, it was in the form of a poem somebody had written, a letter to my doctors. Right. It is ostensibly written by a newborn. So it says, the newborn says, I was born premature, 4 months early. You intubated me, put me on a ventilator because you could. Right? My lungs were weak. You gave me surfactant and waited for them to grow because you could. My lungs grew, but not enough. You gave me a tracheostomy and portable ventilator because you could. So on and so forth. So many interventions. There was a buildup in the brain, so a VP shunt was placed. So on and so forth. In the end, it all ended futilely. So is this all the best we can do? Does it mean because we could, we interpret that to mean we must? These are the questions. Our decision making, particularly in a prognosis which is unclear at the outset and then become very clear to be not in our favor, how we readjust our treatment goals and how we hold our hands from interfering more when it is clearly not indicated. That is the sort of decision making that we must undertake with every patient, in fact, a very reflective decision making. Why? Because there is ample evidence that disproportionate treatment is harmful in medicine. For the patient, it harms by prolonging death. And of course, it is against bioethical principles of taking a decision which benefits more than it harms. There's a potential benefit and there's a potential harm. So the harms should not outweigh the potential benefits. That is a very important ethical tenet. Then to the family, it causes economic distress, dissatisfaction, and post-traumatic stress disorder, which may last for years. And not to forget the caregiver, that is us. For the caregiver, it causes moral distress, causes compassion fatigue. You do something which is not meaningful. You do something to improve matters, but you're not able to do because of constraints, barriers to make that decision. And then it may lead to dissatisfaction with yourself and even leaving work or attrition. So if we look at the brief look at the ethics and professionalism involved, there are multiple values of caring that is involved in this. So autonomy, beneficence, non-maleficence, justice, and equity are the four pillars of the essentials ethics that we must interweave in every decision that we take. Apart from that, we must integrate evidence-based medicine, setting goals of care appropriately. And then in communication, there must be truth-telling, compassion, and transparency. These are professionalism essentials. We must keep central to everything the patient. Patient-centric means the best interests of the patient. In critical care, we also become family-centric because most of the patients, 95%, are not competent to deal directly with the caregivers, and therefore we have to involve the family for virtually everybody and integrate their reporting of the value system that the patient holds. And above all, this is where holistic care comes into full force and full manifestation in the form of mitigation of suffering. The fourfold suffering, there's a physical pain, there is emotional distress, there is psychological pain, there is existential pain, there is spiritual pain. So the four dimensions of pain are involved here. So that is called palliation. So how do we manage death and grieving, dying and grieving? This was brought about in depth by the report of the Lancet Commission on the Value of Death by Libby Salnow et al., which was published exactly a year ago in January 22. So their findings were this. They reviewed all about everything, all the intersections on the issue of death and dying. Multiple, there's not only the medical and scientific, but also the social, historical, even the environmental and the religious and everything brought together. And what were their findings? Death, dying, and grieving in the ICU setting needs to be managed with skill and understanding. Ethically grounded practice is best tested in the setting of the ELCO. Quality of death and dying needs attention to ethical principles, communication and palliative care skills, legally informed practice, community participation, and national policy. So let me take a case example, because we must deal with real life situations. We have had a lot of talk. We must also walk the talk. So consider that this was years ago, my own patient, 40-year-old male, a valvular heart surgery was done. This was a heart-lung institute. There was post-operative infection and sepsis, and 3 weeks later, he was on a ventilator, on vasopressor support, IABP support, CRRT, comatose, the works. All right. And day in, day out, the team of doctors were telling the family, look, we are going nowhere. He's not going to improve. He's inevitably going towards his death. The family was anguished. They accept a poor outlook. However, they have other problems. As is so familiar to all of us, they have a financial crisis, they have an emotional crisis, and they are unable to bear costs. So, question one to all of you. Pay attention to these questions. You have one choice. These are the options. What in your practice would be your further management? Would you continue full support till the end? Persuade family to take the patient lama, left against medical advice, or discharge against medical advice, dhamma? De-escalate treatment unilaterally? De-escalate treatment with documented consensus between family and physicians? Now make an honest reply, not what is projected as ideal, but what would you do actually on the ground? Gunadhar, we are getting answers?
Yes. So some of them have answered option 4.
Very good.
Yes, and few are option 1, but majority of them have answered option 4.
I'm truly proud of you, audience and students, because you have your heart in the right place and your professionalism in the right place. Yes, we would de-escalate treatment with documented consensus because of the principle of best interest of the patient. The harms outweigh benefits in a situation like this with all these interventions. But there was a conflict between the family and the caregivers. Family was told it was illegal to remove support, so lama is the only option. Okay. So this has been a very familiar stand all through. In our units, you would all agree, family is in a confused and a distressful dilemma. They got embroiled in a conflict with the treating team and the hospital management, and a second opinion was sought. So I was a pulmonologist in the hospital, but I doubled up as an ethical and what do you call palliative care specialist and an end-of-life care specialist for this case. So I was invited for a second opinion. How was this conflict resolved at the second consultation? Number one, ensured open conversation and explicit prognostication available options. So this is mandatory for if you must respect autonomy of the patient. Elicited from close family members what the patient would have wanted. Right? This is called substituted judgment. That is placing value upon what the patient would have wanted and eliciting that value from those close to him or her. De-escalation decision taken and documented with signatures of both parties. So there's a consensus between both parties who are involved in the care of the patient, the ordinary caregiver of the family and the professional caregivers of the treating team. So what did we do? We removed the IABP and vasopressors, and expensive antibiotics were stopped. In fact, all expensive medication was stopped because they were meaningless. Dialysis and investigation were futile at this juncture, so we stopped. The palliative care measures were carried out with impeccable assessment and meticulous titration of doses, which is what we owe to the patient at all times. You don't abandon the patient. You only care for the patient even more, as is required by the patient at that juncture. That is mitigation of suffering and pain and ensuring a dignified and peaceful end. So what was the outcome? Peaceful, distress-free end in a few hours. We didn't have to remove the ventilator because the vasopressor support and the IABP having been removed, this could be accomplished without having to extubate the patient. And what is the outcome that's most desired by all intentions? Gratitude expressed by the family. So we owe it to every family to provide them genuine satisfaction, even if the patient is dying or dead. It does not mean the family have to go away dissatisfied, angry, right, and uncomfortable. Question 2 to all of you. Are you ready? The decision is supported by the following principles except. Now there are 4 options, you choose one. Which one of the principles that we are using for an end-of-life decision? patient autonomy expressed through surrogates, refusal of consent for treatment, duty of care by the physician team, financial distress of the family.
Yes, so I request all of you to put your answers in the chat
It is
box.
except, okay? 3 of them are what is ethically correct, 1 of them is not correct. Okay, except.
Yes, so whatever the response we have till now, sir, it is 4.
Yes, that is the not ethical to base these decisions on the financial distress of the family. That's a separate issue. Ethical decision making towards the end of life, particularly for withdrawal or withholding of life support, is based on patient autonomy as expressed through either an appointed surrogate or the next of kin. Refusal of consent for continuation of treatment, which is what the family did on behalf of the patient. And duty of care, this is not a menu card you offer to the family and they tick one and you follow. That's not it. You properly counsel and inform them and help them along in the right decision making, which is what is beneficence. So our responsibility for the patient never ceases. We have a responsibility to express our genuine advice in the circumstances, because lay persons are not equipped to understand it thoroughly and fully, and you are obliged to help them to understand thoroughly.
Sir, can I interrupt here? So one questions in the chat box, like if
Yes.
suppose the family is affordable. Sorry, the outlook is good, but the family is not affordable. So what does the ethics says that point of time? How does we proceed in such kind of cases? So one question is asked by Dr. Girish.
Very, very important, Girish. When the outlook is good, or there is a possibility, even if the outlook is not excellent, but there is a possibility of retrieval, of cure, or meaningful survival, then you cannot take an end of life decision, even if the family runs out of money. So the options thereof, what do we actually do? What do I do for my patients? I look for subsidy within the hospital, right? Talk to the administration, see if you can be fiscally more efficient with your prescription, right? And then give a case summary to the family so that they can approach other hospitals which are maybe less expensive, or a government hospital where the patient can be safely transferred. So you see, there are some hospitals we have who have a free quota. Okay, a number of hospitals have a free quota. So a number of hospitals do that. They shift the patient under the free category. A number of hospitals give subsidy. Now, these are published as well. I'm not speaking out of my hat. I can't name the hospitals, but these examples exist. There is a very well-known hospital which gives subsidies up to 30 to 40% from a donor pool, right? They accumulate donations and then use for those people who are not affordable. So these options exist, and nowadays, of course, people do through the social media, try to get money enough to meet the expenses. We must be creative in our thinking to make the patient well in those circumstances of financial constraints, but the option is not taking a premature end of life decision. But I must say that we are not fiscally efficient in many, many cases we are treating. The consumables and antibiotics alone form about 50% of the expense. This has been estimated. But if you are careful in what you prescribe, through properly applied evidence-based medicine, you could reduce it to less than 30%. Now, any mitigation of financial burden will help the family endure and be resilient for some more time, which you can utilize to save the patient's life. Does that satisfy you?
Yes, absolutely.
Yeah, then we can move on to the case number 2.
Yes, sir.
Now, this is a more complex decision making. Oh, this is a question 2. This question 2 is done. Now, case 2. Case number 2, pay careful attention. This is also many years ago under my care. A 75 years male, a retired bureaucrat, transferred from another hospital for weaning failure. He had spent a month on a ventilator in another hospital, and repeated attempts failed, and therefore he was transferred to our hospital, which they believed would be successful in being able to wean. He was on tracheostomy, fully alert and communicative in writing and in speech, hoarse though the voice was, with blocking the tracheostomy, the stoma, he could communicate. The background was metastatic prostatic cancer and other comorbidities, including hypertrophic obstructive cardiomyopathy with chronic heart failure. Treatment options for both these conditions had been exhausted or found unfeasible. So the situation, what is the problem in the situation? Is the patient persistently, consistently pleaded not to be on the mechanical ventilator or on any form of life support. His family consisted of his wife, who had passed away 2 years ago, his daughter and a son-in-law. The daughter and son-in-law were fully with him in his decision, in his wishes. They wanted to respect his wishes that he didn't want to be on a ventilator. For him, it was intolerable and undignified. He said, I have fulfilled all my responsibilities. I've lost my wife, dear wife, 2 years previously. All I want to do is to be able to play with my grandson. And if I can't do that, my life is meaningless. What would you do for this patient, ladies and gentlemen? Continue full support till the end, saying law does not support withdrawal of life support? Sedate and paralyze the patient and gradually dial down support? Send the patient home as lama? Fulfill ethical obligations of respect for autonomy, beneficence, and non-maleficence? So what would you all do? Can you respond?
Yeah, so majority of response is for option 4, sir.
That gladdens my heart. So there's no running away from your obligations. No running away from taking a difficult ethical decision. So over the wishes of the patient, you can't be providing full support and becoming deaf to his entreaties. Sedating and paralyzing and gradually dialing down is not acceptable. Lama, as I said, is a most thoughtless and cruel action, because you're saying, I'm abandoning you. I want to protect myself legally. That's all I want to do. How did we resolve this issue? Initially, myself and my team were a bit worried about a withdrawal decision for reason of legal liability. We are wondering the law would hold us guilty of some crime which they haven't defined yet. If I did that and took a decision respectful of autonomy. Unclear prognosis in the short term. I wasn't absolutely sure, without a trace of doubt, that I won't be able to wean this patient. Okay, so wanted to give a try, give a go, on and off ventilator, all sorts of modes of ventilation tried, and de-escalation on ventilator, and also tried to support the heart with HOCM. Of course, the cardiac opinions and all were implemented. After 3 weeks, we were just as we were in ground zero, and the patient was now getting a bit angry with us. He was insistent, and several weaning attempts had already failed. He said, you I trust you, doctor. I trust you now. Continue to trust you, but you are not helping me. You're continuing to overrule my wishes. So we took the decision. Counseling and documentation directly recording the patient's refusal, because nobody can override refusal of consent. That is clear in law. That a clearly stated refusal, consistently stated refusal by a patient will not allow you to continue or to initiate any treatment. That is unacceptable to the patient. So we weaned the patient, and when the patient did not do well after a few hours, because of the refusal of consent to reinitiate the ventilator, we did not do so, but we provided full palliative care support. Now, what was the outcome? There was family and physicians' concurrence with the decision, and we followed the ISCCM guidelines. At that time, ISCCM guidelines existed in 2005, as you remember. The weaning was done respecting the patient consent of refusal of consent, and mechanical ventilator was not put back. Anticipatory and ongoing palliative care was continued, and patient died peacefully after several hours, with mitigation of moral distress among family members and caregivers. Anybody with comments?
Sir, one thing like not to put on ventilator, like do not intubate consent. And second thing is withdrawal of ventilator, any patient who is on ventilator. So what are the ethics and legal issues involved in it, sir?
Excellent. Now, withdrawal and withholding are same ethically. According to the authorities on biomedical ethics, I would refer you to the book by Beauchamp and Childress. The first edition was in 1982. The Principles of Bioethics. Now, this is the modern bioethics which is being followed in our decisions. Withdrawal and withholding both stand on the same level because they stem from the fact that any initiation or continuation of a life support is no longer in the best interest of the patient. So in fact, everything is like a withholding only. As we saw, we withdrew, but we withheld putting back. So essentially everything is whether you interrupt a support or you don't initiate a support, both are a form of withholding only. And the death of the patient is not because of the withdrawal or withholding. Death of the patient is because of the basic disease condition or conditions that have driven the patient to a terminal illness and without a hope for meaningful recovery. So we have a three-way obligation: ethical, professional, and legal principles. All three have to go together. There is now a statutory force to the common law right of refusing treatment. What is common law? Common law is what is existent in practice. It is not through a legislation, but refusal of consent is already there. You see, you can't do even a procedure which is 100% life-saving to the patient if the patient does not consent. And if you do overriding the consent, then it is battery. So what do we know of the law? Is withholding withdrawal permissible by Indian law? One short answer is yes. It's permissible by law, by constitutional validation and common law. Why constitutional validation? Because of two landmark judgments which came in 2017 and then 2018. 2017 was a right to privacy, which includes the right to refuse life-sustaining treatment. This is Justice Retired Puttaswamy versus the Union of India. Now, the second is Common Cause versus the Union of India, 2018. which put together both autonomy and the privacy as extension of your right to life. So both of them are your rights as well. And if you take both together, you have the right to direct the way your medical treatment will be conducted, which is right of refusal of any medical treatment you don't want, or being fully informed is not going to help you. So as an extension of autonomy, the right to living will also exist, because the autonomy doesn't go away just because you lose consciousness, because you lose you see the you're comatose, or you lose capacity, you lose the competence to express yourself. It doesn't mean your rights disappear. They don't disappear. Your rights are only represented by somebody else, either by an instrument such as an advance will, your right, which is an instrument which represents your wishes and values, or failing which you have your next of kin, family, or a significant other, or somebody you had appointed as a part of the instrument of living will and advance medical directive as your legal proxy. I want to also point out that there are multiple definitions in relation to end-of-life care and decision-making. One mustn't confuse or conflate with euthanasia. All right, euthanasia is one end of the spectrum of respecting autonomy. Active euthanasia is intentional assistance in killing of a patient as an act of mercy, allowed in a select few countries and states of the US. But what we are talking about is the vast majority of cases wherein you take a treatment limiting decision, which is the other end of the spectrum. Simplest decision is DNAR. Do not attempt resuscitation. Then withholding and withdrawal. So this is the whole spectrum. So withholding, withdrawal, and DNAR, they are not any form of euthanasia. They are treatment limiting decisions or foregoing of life support decisions, which is very common. Which, as I said, any decision not to initiate or to stop treatment is very common in medical practice, and this is not to be confused with euthanasia. There are 25 definitions in this book published by ICMR through a consensus process within a task force of which I was also a member. So this is by experts from India across many specialities who have framed these definitions. Please go through them. They are in the public domain. So graphically, I can show you what is withholding and withdrawal are. Withholding is not initiating an activity of life support and technology intervention. Withdrawing is once started, you interrupt. Okay, because it's no longer useful or no longer wanted by the patient or the patient's representatives. So you can see that end-of-life care practices vary across the world. There are, it depends on the ecosystem of national culture, policy, institutional policy, and also individual families and physicians. Isn't it? We can see that as a witness. There may be different cultural ethos or different approaches even within the same institute amongst different ICUs. So there is an impact of the national culture, institutional policy on individual clinicians who may have their own biases or values and wishes or religious beliefs, which may facilitate or hamper ethical decision making. Similarly, the patient and family may not have had enough discussion on death and dying. They may have their own value systems which may facilitate or hamper these decisions. Now, this is the diagrammatic representation of all this interplay by somebody who has been a pioneer on in the end of life care and quality improvement and communication, Randall Curtis from Seattle, a name to remember because he's one of the pioneers in this field. So what is happening in India? End of life care, foregoing of life support in India. We have the following publications. So you can see the list: Kapadia et al. In 2005, Money et al., my team in 2009, Tata Memorial Hospital Experience, which is a personal communication, and then INDICAPS 1 and 2 survey, which was conducted by the ISCCM under the leadership of Jiggy Divatia, multi-center studies, observation study, then Asian survey, ACME, multi-national observational studies of physician attitudes, and CMC Vellore study in 2019, single center retrospect. So what did the INDICAP study show? The 1 and 2 reveal 1/3 of deaths via LAMA, terminal discharges. So this is the sad part of it. We don't take enough a formal end of life decision and then a systematic caring of the patient through the dying process. We are not doing that. We are sidestepping all this responsibility by sending the patient LAMA. So across 124 Indian ICUs, 4,209 patients between 2010 and 11, and then 2011 it should read, 132 ICUs, 4,669 patients in 2018 and 2019. So these are two studies. Both are point prevalence studies, that is on a single day. You see how many patients are there and all the different categories of patients. And then we also could call how many patients went LAMA. 80% of these are in the private sector, 546 deaths, out of which 183 terminal discharges. So this increased in INDICAP 2. So rather than improve in our practices towards the care of the dying, this increased from 4.5% to 7.6%, the LAMA rate or terminal discharge rate. And 70% of deaths had no form of limitation. So this is pretty contrary to what is happening in the rest of the world. Now I will make you think a little bit about LAMA and what we are actually doing. It's a pernicious practice that violates basic ethical tenets. Why? Because it's like washing one's hands off, like Pontius Pilate did, right? Washing one's hands off when faced with an ethical or moral problem. There is no attempt to address issues of foregoing of life support or dignity in death. No attempt. There's only an escape. Only a crude attempt at escaping legal liabilities, potential legal liabilities, or perceived legal liabilities. The patient and family are left to their fate to face death without palliative care. And as a widely publicized case shown, LAMA is no protection against litigation. You will find that this case I have quoted here in the public domain, Adya Singh versus hospital. So where they sent the patient, a young teenager, through LAMA, but it only led to great suffering and a big litigation. Let me tell you, most of the cases, as we know, in the ICU, it starts with the prognosis being not so very clear. There's no black and white here. There are shades of gray. You have to navigate, negotiate almost on a daily basis to see where we are heading. So when we are unclear at the outset, we don't know whether the patient is going to benefit clearly or clearly not. So that clarity is there only in the minority of cases. The majority, you may have to give a trial of intensive care. So why I'm saying that is, if you put somebody on a ventilator, it's not for all times to come, provided there is a trajectory of improvement or there is a reasonable plus, clinical possibility of a meaningful survival. So, time-limited trials are to achieve a reasonable degree of clarity and certainty and assessment of a realistic chance of a meaningful recovery. I often do this time-limited trial, give ourselves, say, 2 days, 3 days. We talk to the family, we say, let's see, over the next 2 to 3 days, if things are not working, we'll let you know. We will openly tell you. We will not hide things and something. So it is a building up of trust between the caregiving team and the families, which is crucial to these family discussions. In the world, what's happening? Let's see in context what is happening. Now, there are precedents in the US since the 70s, the legal precedents and legislations across the world. There are 17 or 20 legislations across the world. You can see all these countries. There's copious data of foregoing life support in the ICUs in the medical community across the world, and medical assistance in death, which is called MAID now, no longer called euthanasia, use modern terms, is increasingly acceptable in high-income countries. And this, the countries allowing MAID is now increasing every year. So Indian data is, of course, very sparse. I'll draw your attention to one of the latest publications of 2019, Ethicus 2. Ethicus 2 published in 2019, whereas Ethicus 1 was published in year 2000 or 2001. So in the period 15 years, how have the practices changed in Europe across the ICUs? That was the question. Treatment limitations occurred significantly more frequently it rose from nearly 70% to nearly 90%. So these decisions, although complex, although nuanced, needing expertise, beset with a lot of gray areas, even then they're getting easier and easier in Europe. And so it has been easier in the US as well because of fairly settled culture and laws. Death without any limitation, life-prolonging therapies occurred significantly less frequently as a corollary. And therefore, you also had less people with brain death because fewer people underwent useless CPR. And more nearer home, the dying law in Korea. Now, Korea and other Asian countries for a long time did not have settled laws relating to end-of-life care. You can see in South Korea, dying law was introduced, and this publication was there in 2022. And they assessed the family satisfaction through quality of dying in death. There are 20 items. So through a questionnaire of the families, there was improvement in almost all the items of quality of death and dying. In India, we had this publication in 2014, which is the ISCCM IAPC publication coming together for the care of the dying, an end-of-life care policy and integrated plan of the dying. So this is a comprehensive document running into 24 pages. So please look it up in the net. So you have these steps for end-of-life decision making. There are 14 in all. 4 or 5 of them are of palliative care. So it will be worth your while to go through this algorithm as well, decision-making algorithm. So I won't go into it. This is fairly comprehensive, and if you go through it, it will help you by the bedside. Post 2018, when the Common Cause judgment validated constitutionally the refusal of treatment and foregoing of life support, and also living will or advanced medical directive, we reframed this flow chart. two bodies came together, FICCI, Federation of Indian Chambers of Commerce, and and then also elicit end of life care in India task force, of which I am a member. It is a task force formed by three professional bodies, ISCCM, of which I am the representative, and IAN, of which Dr. Roop Gursahani, a neurologist, IAN is Indian Academy of Neurology, represented by Roop Gursahani, and then Indian Association of Palliative Care, whose representative is Dr. Nagesh, Sri Nagesh Sima from Bangalore. Roop Gursahani is from your own town, Mumbai, from Hinduja Hospital. So you see, we formulated this flow chart, so-called FICCI illicit guidelines, which incorporates the presence or absence of AMD, Advanced Medical Directive. We are obliged to ask the family, does the patient have? Now, Advanced Medical Directive becomes operational only when the patient loses capacity. So assessment of patient's capacity or no capacity to involve himself or herself in a decision-making dialogue is essential. That is the starting point. If you don't have an AMD, which is what is happening in the nearly 99 or more percentage of cases, but eventually, the people holding AMD is going to increase. This is how it evolved elsewhere in the world. So if you don't have, then you work with the family. If you don't have an appointed surrogate, you work with the next of kin, or most importantly, with the spouse, and so on and so forth. If you work with them, have a shared decision-making process, which means there's a conversation. There are conversations which focus on the values the patient might be having, to what he or she would have liked to be or not like to be. Along with that, the caregiver's instinct and obligation of beneficence, that is laying open the facts of the case as honestly as possible, as accurately as possible. If required, go back and forth in an iterative manner to get it as accurately as possible, your diagnosis and prognosis. And then through a shared decision-making process, you take this withdrawal withholding decisions. Now, question number 4. Okay, for those who are nearly asleep now. Okay, now let us look at it. Good end-of-life communication should include all except one is the right, one of them is not quite right. Open disclosure of disease prognosis to the patient when competent, allowing emotional expression of patient and family, allowing family more time to speak, following family decision with minimal discussion.
Yeah, so majority of the answer is 4. It's 4.
4 is following family decision with minimal discussion.
Yes. So
please read the question again. Good end-of-life communication should include all except, correct, right. Number 4 is correct. So all of you have your hearts in the right place. You're not going to just offer a menu card and follow blindly. You're going to guide the family. You're going to navigate them, support them, hold their hands in the route to a right decision. Communication is crucial. Now, this is a painting in the late 19th century, The Doctor, it's called, right? So this is an English painter. You can see how the doctor is sitting, leaning forward. Now, there's a body language of caring. And then cut to modern times. The doctor is facing the computer, facing away from the patient. So you see, humanization of medicine begins here in communication, verbal and non-verbal, caring, compassion, human touch. So communication is more than just providing information, though that's a very crucial, important part. It is more than that. It is also providing this human touch and also supporting the emotion, acknowledging and supporting emotion. A conversation, okay, it's or as equal terms as possible. You are not going to talk down to anybody. You're going to elicit the family side of the story and their concerns. So you can see I'm talking directly with the patient. That's also possible sometimes, occasionally, in the ICU. So you can, in fact, even provide sensitive information to the patient uh, if it is done in a sensitive manner. Majority of the times, this is the way we have to communicate. Sit the family down, and not by the corridor, not in the lift, but properly. Do we have the time? We ought to have the time. In fact, it's been calculated, need somewhere on average 11 minutes or so. It may not be exactly 11 minutes every time. Sometimes it may be more, sometimes it may be less, but you must incorporate it in your daily habits. Basic principles of end-of-life communication. I'll briefly run you through what are the basic principles. There is a lot of research on this, and there is a lot of understanding. So patients want to be told the truth. Telling the truth doesn't render them more anxious or more depressed. It's quite the contrary. This has been proven time and again. It's, of course, the way you do it. You will not harm the patient by discussing end-of-life issues. Anxiety is common on both sides, both to the caregiver and the care receiver. Patients have goals and priorities besides living longer, and they have to prepare for death very often. Discussions on priorities and goals empowers you to care for the patient better. So last question. DNAR is a form of euthanasia, is not allowed in India, should not be documented, is a medical intervention to be prescribed only when indicated. A little more tough, isn't it?
Yeah, more response.
Understandably, this is more difficult.
So the two students have replied. It is the option 4.
Exactly. Well, whoever's answered is spot on. It's not a euthanasia at all. On the contrary, it is on the other end of the spectrum of foregoing of life support. It's not allowed in India, not correct. We have got now an ICMR, guidelines on it. Should not be documented. No, that is not the advice of the document of the guideline. Yes, it's a medical intervention like any other. And every medical intervention has to be appropriate, has to be indicated. So we won't go through the definition. We all know what it is. And DNAR happens to be prevalent in medical practice for over 50 years now. All right, the first DNAR order was probably written in 1974. And it was codified law in the US in 1988. So we are a little behind in these practices. We must close the gap. So this is the ICMR consensus guidelines on do not attempt resuscitation. Please go through this. These are the algorithms to follow in that decision making. This also in a certain proportion of these decisions, a shared decision making. There are some complicated procedural guidelines laid down by the Supreme Court in 2018, and which is hampering more widespread use of those provisions in law. Therefore, there is an application for clarification and modification, which is currently being heard. Today, I'm coming from the Supreme Court, the third day of deliberation. So hopefully, we will have more clarification and simplification of these guidelines and make our practices easier. So I would like to conclude now, and these are the points to take home. Foregoing of life support denotes withdrawal, withholding, and DNAR. It's an important decision making towards improving the care of the dying, because a burdened care of the dying or burdens which the patients don't want is not the way you want to you want to care for those who are dying. These decisions are complex, needing open and sensitive communication, decision-making, and transparency. Quality palliative care replaces curative treatments. The COVID-19 pandemic has more than ever highlighted the need for humane and pragmatic end-of-life decisions. Because COVID brought to light the need for triaging, need for careful resource utilization. If most of our ICUs are locked up in futile care, then we are denying care for those who will benefit from it. And lastly, the landmark Supreme Court judgments have enabled us to execute AMD withdrawal withholding procedures recommended by the SCR being now looked at again by the Supreme Court, and the efforts to simplify the problematic steps are on. The professional bodies have laid out pragmatic procedural guidelines in line with the rest of the world, and there's a lot of advocacy going on across several professional societies today. Thank you very much.
Thank you, sir.
And Gunadhar, if there are a few minutes for questions, then I would take it. Yeah.
Yes, sir. Sir, there are 4 questions. So can we take, sir, if you have?
Sure, please go ahead. Yeah.
So, one question is like how to document the DNA, sir? By
See, there is a form available as an appendix to that guidelines. But you see, you don't have to have a form. You can document decisions in the case file. You can say that what should be the content. Content is for the following reasons. The option of DNAR was offered to the family and discussed, or offered to the patient and discussed. And then a shared decision making was taken, right? And so you write this. Or if you've taken a unilateral decision for DNAR, sometimes that happens, you have to take it in a split-second moment, you don't have enough time for discussion, or it is very clearly futile. Then you say that by the reason of futility, because the patient had advanced metastatic disease, age, or whatever, you have those medical situations or scenarios where it is futile to offer it, then you don't have to offer. But you please record. See, whatever we do, if we record, it shows 2 things. That you have given thought to it. Number 2, you are transparent. You have nothing to hide. Transparency will build trust. Transparency will hold in court as well.
Right, sir. So another question is like if the immediate blood relatives are not available, so who actually signed the DNAR consent?
See, if blood relations are not, sometimes it happens that there is no family, right?
Yes.
In that case, we have, as in any medical situation, not just end of life, you have somebody who has come in an emergency, you don't have, he's come anonymous, there is nobody around. Then 2 or more physicians take a best interest decision. It should not be one person. Even our Supreme Court says it should be multiple doctors, so-called collegiate decision-making. This is also endorsed by several other jurisdictions across the world, that in a situation like that, it should be a collective decision rather than an individual decision to ensure that we minimize the chances of error.
Okay, sir. Sir, another question is by Dr. Deepak. He's actually from Delhi Metro Hospital. So he put it a very important point. Like it is very difficult to counsel a relative for withdrawal and withhold in small cities in ICUs, even if the ICUs is well equipped, because they have the option to shift the patient to Metro City Hospital in Delhi. Everybody except the FATE. So if the patient is going Lama in that case to Delhi Hospital on our counseling, then the management has an issue. So is still this the Lama responsibility or the legal responsibility is the same in such cases?
You see, of course, all lamas are not the same. There are certain circumstances where it's justified. You don't do a lama then. If the patient wants to shift to another hospital, which the family consider to be a higher level hospital or have more confidence in. You can put that in a discharge on request. And, you don't have to necessarily make it LAMA. LAMA means there is a break in the communication between the family and the treating team. It is a sort of a break in a relationship. So we don't need to do that. You can have an amicable coming together in a decision and in the patient's interest. See, when I say LAMA is a pernicious, it is for those cases where you wash your hands off, where you say you fend for yourself, you can't afford, you can't stay with us. By and large, those sort of decisions should be avoided, and they have a serious ethical violation, to my mind. But if they are being transferred to another facility, which they believe in, or which may be at a higher level of ICU, then that is all right. That doesn't have to result in a break in relationship.
Right, sir. And like in patients who actually where this end of life care is being practiced, so is there any need for monitor them with BIS monitoring to know that there is absolutely they don't feel pain or there is no cerebral major cerebral activity is going on? So is
No,
there
nobody recommends it. You don't need a BIS monitoring for good palliative care. What is discernible and visible, that's what all palliative care specialists are doing. They're not using these monitoring, across the world, I mean. So, but I mean, you can use it, but then we don't need so much technology. We want to dampen down technology and emphasize the humane care in a situation of dying. Now, all the technology used where there are curative options still open.
Okay, sir. Sir, the continuation to the previous question. So if the patient is already intubated and on ventilator, and now he is basically fulfilling the criteria of terminal illness, and attenders wanted to stop ventilator after counseling.
Sure.
So can we take end of life care consent and withdraw the ventilator?
Of course you can. I showed you in case number 2.
Yes, sir.
And we discussed withdrawal and withholding being at the same level ethically. All ethicists across the world, or a majority of them, okay, there's always a controversy somewhere or the other, but
Yes.
then majority and the current widely accepted ethical norm is withdrawal, withholding are the same. Now, if you read Beauchamp and Childress, who have the seminal work of the fundamentals of biomedical ethics written, and I mean that's into the 7th edition now. What do they say? If you hold them to be different, we'll be going wrong in 2 ways. If you say withholding is possible, withdrawal is not possible, right? What will happen? You are not going to give a trial of intensive care to people who may benefit. As I said, you can't be 100% sure in the bulk of the cases. So you don't have the option of having a intensive care trial. Supposing you do have, you cannot withdraw. No, either you undertreat the patient this way, or you would overtreat the patient if you say withdrawal is not possible. Because once ventilated, you down the line, you discover that this is not going anywhere. You have imprisoned the body with a ventilator. You don't have the option to come back.
Absolutely.
So that is not correct, isn't it? It is like a chakra view. You know how to get in, you can't come out. So that is a sort of trap we fall into if we separate withdrawal and withholding as different. As it may be a more difficult decision. Withdrawal may be perceived as more difficult. It may be more difficult to implement, okay, because of the perceptions. However, ethically and legally, there is no difference. Even in our law, in the 2018 judgment, they have made no distinction between withdrawal and withholding for everybody's information. Yeah.
Yes, because this is one of the misconception and myths, I can say. Many of
majority of our fears go away when we get well informed. What I'm saying is, when you get so very well informed about mechanical ventilation, about ECMO, about fluid therapy, sepsis, your confidence grows as you know more and more about it.
Right, sir.
Similarly, please, every technological intervention must have an ethical underpinning. And before legal understanding, you need ethical underpinning. Because legality is only to support ethical practice. Okay?
Right, sir.
Otherwise, there will be no role of law. Law is supportive of ethical practice. And ethical practice comes from our own professional understanding. It is not imposed on you by anybody else. So please let us improve our understanding of medical ethics, biomedical ethics, particularly as applied in intensive care. Because intensive care is very complex. It involves a lot of technology. It involves a lot of complex decision making. It involves prognostication day after day. So without these underpinnings, this framework, we are going to be fairly superficial in our handling of our patients.
Yes, sir. So it's rightly pointed out by you. Actually, it is the perception actually which seems difficult, but
Yeah.
ethically and legally, the intensivist is not wrong actually if we practice withdrawal.
Yes, not wrong. And see, our ISCCM is holding the torch for this campaign of creating an ethical ecosystem in this country. So let us be proud of what we are doing together. All right. And then each one of us, if we practice like this will become the norm. After all, laws come out of norms established in the profession, not the other way around.
Absolutely, sir. Absolutely. And one question is by Dr. Sahina. So does this DNR, sir, comes under right to refusal?
Of
Like,
course, it comes under two things. Right to refusal is, of course, there. And it also comes under beneficence and non-maleficence. Whatever is not required or not indicated, you don't advise, do you? You don't advise. For instance, would you advise so there is no separate mention of DNAR in the courts, but it is a part of withholding, obviously. DNAR is a withholding, and DNAR, a statutory body, ICMR, has given you a guideline. Please have confidence in practicing ethically. You don't have to make it so complicated.
right. So it's a one live means it's a in one hospital. Like one question is being put here. So in one hospital, the intensivist faced a challenge. Like one son is against the end of life care and he's on psychiatric medication. This is a true story. He's emotionally
Sure.
attached to his mother, and the other son brought a lawyer to withdraw the ventilator. So recently he faced this case actually. So in these scenarios, so anybody like such patients or relatives which are on psychiatric or medications, so how justified their will is in decision
See,
making?
one glove doesn't fit all, does it? You can't have one formula to cover all possibilities in human life. So in a situation like that, you see, you go back to the drawing board, again ask yourself, what are the principles I'm following or not following or violating?
Okay.
If one son is mentally challenged and there is another son who is taking the decisions, right? If you have evidence of mental challenge or insanity in the other patient, then you are probably reasonable in taking the opinion of the other son. But if you don't have any of these, it's a conflict between families. The family conflict must resolve before you take a good end of life decision. You understand? Because it is not something you are imposing on the family. You're giving an option to the family. Okay, you don't have to take full support for the patient as the only option. There's the option of withholding or withdrawal. These options exist. There has to be a family consensus. Now, I had another question from another hospital. They contacted me to resolve an issue where there was a conflict between the wife and the son. The wife is in the hierarchy higher than the son as far as relationships are concerned. There is no formal enunciation of hierarchy in our law. However, one hierarchy exists in our TOA Act, Transplantation of Human
1994.
Organ, 1994, where there is a hierarchy of surrogates mentioned. This hierarchy of surrogates is also mentioned in the AIMS institutional end of life care policy. You can look that up. That's also in the public domain. So AIMS is also now taking end of life decisions of treatment limitation. You have a hierarchy, so you may follow that if it comes to that. But the best thing. What is the best thing? Even if one son is challenged in some way, you have to sit that son down and talk to him kindly. That is an obligation we have. We don't have to impose anything. We give him as an option, because sometimes on day one, it may be unacceptable to you, but on day 4, you may thaw a little, and on day 7, you may accept. As they say the evolution, as they see the evolution of what is happening to the patient, they themselves realize that probably it will be better for the patient not to have these imposed. Let us be kind caregivers. I think it can make a lot of difference to our decision making.
Absolutely, sir. Absolutely. So I think with no more questions, any questions from Dr. Ganesh, Anjana, and Ilyas? So I think there is no more questions. So I think
Thank you.
so we can.
Thank you. I hope everybody enjoyed the session.
Yes, sir. It was absolutely a wonderful session, and it made the point very clear and crystal clear, actually, I can say. So, but they have to read more and more to understand the principles and ethics, because
No escaping that. We have to be informed.
yes, because it's a ever changing and evolving branch.
Yes,
Going
it
mad,
is.
sir. So I really thanks to you, sir, on the behalf of Apollo Hospital, Navi Mumbai, our critical care department, and all the delegates and students who are here. It is a very eye-opener topic, and we would like to have you such topics more and more in the future. So thank you all. And with this, I would like to conclude the session. And thank you once again, sir. Thanks to all who has participated today. And again, we have an interesting session on the next week. So about the neurocritical care. So that I will be posting, sir. I'll send you the link also. Thank you, sir.
Thank you very much, all.
Thank
Bye-bye.
you. Thanks.